In a world where the importance of sleep and airway health for kids is gaining so much momentum, we're here to provide you with a clear pathway through the maze of information. Join us as we connect with experts, share real-life stories, and break down the complexities that surround this critical issue. From screening techniques to collaboration with our medical colleagues, we're here to empower you with actionable insights and a supportive community. Let's navigate the path together to healthier sleep, brighter futures, and happier families. This is ASAP Pathway. Hey, everybody. Hi, friends. Welcome back to another episode of the ASAP Pathway podcast. Your hosts today are myself, Dr. Stacy, and Dr. Tracey. And we have the one and only Dr. Reza Movahed on with us today. Many of you in the Airway world are very familiar with him. But for those of you who may not be, I would love to do just kind of a small sample of who he is. It's very, I could go on and on and on about his bio, but I'm going to have it abbreviated today. Dr. Movahed is an oral and maxillofacial surgeon in private practice serving the greater St. Louis area, San Francisco Bay Area, and patients from across the country. His private practice, Movahed OMS, concentrates in treating patients with dentofacial deformities and obstructive sleep apnea requiring corrective jaw surgery, TMJ joint surgery, and combined orthognathic and TMJ surgery. After receiving his doctorate in dental medicine from the University of Medicine and Dentistry of New Jersey, he completed his residency program at Nova Southeastern University and a fellowship specializing in TMJ and corrective jaw surgery to manage dentofacial deformities. He is a clinical assistant professor at the St. Louis University Department of Orthodontics, where he lectures on surgical orthodontics and takes part in multidisciplinary ortho-surgical cases with residents. He has written multiple chapters for books concentrating in obstructive sleep apnea, joint and corrective jaw surgery, numerous scientific articles, and is the co-author of a textbook which focuses on treatments for sleep apnea. In his spare time, he is a painter and a musician, and I've experienced both of those, which are pretty cool. Welcome, Reza.
Thank you for having me.
So excited to have you today. It's going to be different today, folks. So let me just give you a little heads up as to how. We're just having a conversation among friends, hopefully getting some information out to help people that are on the journey of what is best for them, best for their patients. We're going to have some visuals today. So those of you listening, we're going to try our darndest to remember you may not be able to see the screen. But if you would like to hop over to the YouTube channel, where you'll be able to see the images that he's showing. But we're going to work really hard. And we'll nudge each other if we're not describing what's on the screen a little bit here. But we just wanted to have, Reza, you and I have talked over the years. We've known each other for years.
Over the years. Good
years.
God. Yeah.
And we've been on this journey together. And what we say repeatedly, and is just how much we've changed from when we met each other and how we were starting in our craft, right? And then what we're doing now, so different. And what we'll be doing now, 3 years from now, will be different probably from what we're doing now. So it's so dynamic and changing. And with that being said, you know, Tracy and I say this a lot. The information is coming out. It's like a fire hose. You know, it went from drip, drip, drip about Airway to it's a fire hose coming at us.
Yeah.
And for the lay person, or let's just even say, golly, the average dentist, knowing how to refer their patient appropriately or even what to look for, it's a lot.
Yeah.
A lot of information, a lot of data. So we wanted to dive in and just start talking about some topics. Tracy, you had some great talking points you wanted to hit on today.
Yeah, I mean, so I'm excited, but I mean, I'll let Reza start, with what you have presented, but like you said, I think.
Sure. We can't break it down to small bits and pieces because there's obviously every one of these topics that we're going to talk about today, which are important topics. Each one of them could be a multiple hour talk. We know that. And, for the most part, really what we get to do is quite transformative for our patients. And we can make changes as far as asymmetry of the face is concerned, getting the bites together. Over the years, I've added to the list of things that I really care about, which we need. Lip competence is a big one there. Taking care of asymmetries, function, airway, bite, but in general, better quality of life and wellness for our patients. And we're in a golden age of what we're doing in general for our patients who deal with dental facial deformities, obstructive sleep apnea, and TMD issues. Truly a golden age. And as you mentioned, the amount of knowledge coming out, the plethora of knowledge coming out, it went from drip to right now it's a water fountain, that is coming at high pressure for us. And dimension-wise, if we don't address all the dimensions, we're really missing the point. Because we know now, we know a lot more about the transverse dimension, which was for the most part forgotten dimension. The forgotten joint in the body has always been temporomandibular joint, which is the foundation for stability, function, and face. And we also, one of the things that is really on the radar for me right now, and I was speaking at the university last week, and we were talking with the surgeon, Dr. Sullivan, what we were talking about that what is the difference in terms of the airway changes between a prosthetic joint advancement of the mandible versus sagittal split, and the width of the angle on how that widens the posterior mandible and how the effect would be different. We have so much research to do. We have so much to understand, but there is the basics we have in our hand. We just are refining it, and also the systemic portion of what's involved with sleep apnea. You can't just go and do a surgery and expect a great outcome. You can't do it. Your patients are going to feel not going to feel 100%. You have to pay attention to patients that will live in altitudes, patients who have inflammatory issues in their bodies. If those are not addressed, we're missing the point. If a patient has a high BMI, and you take them to the operating room and do MMA for them, don't expect great results. And it's no longer one man treating or one woman treating these cases and say, hey, I'm the victorious one, I'm the only one. I can't do what I do without the help of the people involved in the case, the help of periodontists, which is a major new addition to the repertoire of what we use for our patients, sleep medicine doc, TMD doc, and rheumatologist. The list just goes on.
Yes.
And we have to really pay attention to that. So in a lot of ways, we have to now break things down to the transverse dimension and AP dimension. And, we have a lot of options for each one of them. And we can get a bit into detail about that. We've always known for the maxilla and mandible, looking into it, that we have MMA has been a tried and true technique and way of moving the upper jaw and lower jaw to increase the airway. But not all the patients would also get the best outcome because they haven't been studied properly. There are patients that the movements are heavy. We have to resort to other techniques to advance the jaws. This patient has about 16 millimeter deficiency. We did advancement of the upper jaw with the hyperdrive system, and we got amazing airway. We just did his MMA. The profile changes are just out of this world for him. Distraction from mandible. Oh, go ahead, Tracy.
Just for the layman term for some of our audience, MMA is basically you're advancing both jaws forward, right?
Correct. Let's go to that. That would be an MMA. As you can see, you see the plates in the upper jaw.
Yeah.
In the lower jaw. And that's when the upper jaw and lower jaw would get advanced. And as a result, the airway expands also. And we've done a lot of fluid dynamic studies on the airway. And we know that the velocity gets lower. The pressure drop changes, okay? And if we increase the volume of the airway by 30 to 40%, we need only about 1/10 of the effort to move the air. And it's the difference between the laminar and turbulent flow, which is Eddy's viscosity number and Reynolds number. Those are the ones that we can assess it for. That's in the world of fluid dynamics. That's
Yes.
exactly what's used in aeronautics. Is same thing goes on with our airway. But the one component that's different really is the soft tissue and how stable the soft tissue is. And that part is something that we have to assess with drug-induced sleep endoscopy. That's taken a major role in my practice. And we came up with a design to be able to move the jaws, and we'll get to it as we speak, to be able to move the jaws in different lower jaw, which is going to be the only one that we can move in a supine position, with different splints of 4, 6, 8, 10, and see how that soft tissue behaves. And that's, you can take two people that have exactly the same airway, same BMI, and you put them on the table and move one of them 8 millimeters, and the airway barely opens up, while for the other one, it opens up heavily 4 times. Okay. And then the flip side of that is also this, is that there are patients that we don't see that much airway change on the scan, but because the airway is held taut forward, then the collapse is less. I never forget this case. It's a case that we did about 2 years ago. This young man came to us and he was suffering from sleep apnea heavily. And we advanced the upper jaw about 11.5 millimeters and 26 millimeters in the pagonion. I was so confident. Hey, listen, I'm going to come back to the room post-op the week after surgery, 3 days after surgery, and I'm going to see this ginormous airway. And I saw no more than 30 to 40% changes. Typically I see airway, as you can see, for example, in this patient right here, with that kind of a movement. But
So Reza,
go ahead, Tracy.
Just for like the audience, drug-induced sleep endoscopy is when you stick a tube up your nose, down the airway, and you actually assess the collapsibility. So
Yeah.
my understanding is you're probably one of the few oral surgeons that do this test to predict the success rate of your surgery.
Correct.
If it's going to happen. So I think that's really important for our viewers to know.
You know what? Let's just show what that would be, so we give full-on context to that.
For our viewers,
some imagery. Go ahead.
Yeah, for our listeners, double jaw advancement is probably one of the most researched airway procedures to date. Now, even though that we have a lot of new research on transverse, but would you arguably say like that's where your field is, and you're just now trying to understand the predictability of the procedure? How much do you need?
Yes, exactly. And it's very simple, Tracy, for an oral maxillofacial surgeon. As a matter of fact, it's the easiest. Most of our ENT colleagues, that have to do this, they have to go to the operating room to do it.
Mm-hmm.
As an oral maxillofacial surgeon, I sedate patients all the time. I'm very comfortable with that in office. So we try to use drugs that are very much simulate sleep as good as possible. Propofol by itself, or Precedex, either or. Precedex is a newer one that we're adding to the list. It's a drug that's been around for over 15 years now. It's affordable now, as a matter of fact. It used to be a lot more expensive. But those two really mimic sleep the best. And that's also the things that I learned through this process, is that you can't just go ahead and do the drug-induced sleep endoscopy and immediately and get the result. A lot of our patients with obstructive sleep apnea, they have so much fight and flight. Mm-hmm. The muscles, the soft tissue is so taut, you have to let them settle into sleep. And then you see the changes. There's a lot of patience that takes place with this. And we've changed this. We changed the way that we go about this. It's not a 5-10 minute, wham, bam, thank you, ma'am, kind of process. So for us, since it's only the lower jaw that comes forward here, that shows that what an MMA is basically, right? What would be with the DISE procedure that we do, we only can move the lower jaw forward. In order to have a reference point, and we're the first ones to do it, reference point, with virtual surgical planning, we simulate counterclockwise rotation of the lower jaw, down and forward. We know exactly the degree that it's going to be. And as far as the occlusal plane is concerned, and and put a splint in that the upper teeth and lower teeth would go in, keep the patient in that, again, supine position while holding the jaw together, and then assess the airway. So in this case, as you can see here, on the left side, there's no advancement. You can see the soft palate is collapsed.
Yep.
Okay. Now, the lower jaw, and also one more thing that this helps us with is that it helps us look at the aesthetics of where the lower jaw would be. So we can present that to the patient and say, hey, we're going to move you forward. People do care about their looks as well. You can push someone forward heavily, and they're going to be primate looking, and their sleep apnea is gone, but they're not going to feel great about themselves every day. Look in the mirror. So we do owe it to our patients to do that. And I always ask the patient, what percentage aesthetics matters to you, or what percentage sleep matter to you? And this is on the heavier end, and this might be potentially could address the things with your issues with your sleep apnea, but is not the full maximal movement. But now we actually can see how the airway behaves as far as the video is concerned. So no advancement, full on supine position, mandible resting down and back, and then putting in the 4mm advancing splint, you can see the lateral walls a lot more stable. AP collapse of the soft palate is gone. By the way, we're looking at the soft palate right now. Okay. And then we go to 6, and now take a look. So the top in the 6mm is these two pictures kind of do look the same. That we didn't put the 8mm picture for the patient. The 8mm stands a lot more forward. So that's the only one thing I have to point out. But as far as the DISE is concerned, it is exact. So the top is 0. Now is 6mm. Now you can see the soft palate and the pharyngeal wall have a lot more space. Okay. But when we go to 8, from 0 to 8, now you see everything from the soft palate down to the base of the tongue. The epiglottis is standing erect, and you can see the vocal cords. Yeah. So to me, the minimum of what we have to do is 8mm, but there's one more caveat here as well. Right now, we have the patient in the splint that's together, bite-wise. The patient is not going to wear a splint at night going to sleep. Yeah. So the mandible will go back at 1 to 2 or 2 to 3mm. So one of the things that, one of the thoughts that I have in this process was to ask some of these patients post-surgery, because we do a DISE at 6 months post-op for most. I can't get every patient to do that because most people go about their lives. But what they could do is to wear a splint that keeps the bite exactly in that final position. Same as you would use a MAD device.
Right. Stabilization. Yeah. Exactly.
Because when you keep the bite together and you look at the drug-induced sleep endoscopy, guess what? The airway opens up quite a bit. And when you let the jaw go and the jaw is hanging down a little bit, that airway is smaller. You know, there's definitely a 20% change, and that is anecdotal. I did not get that from any scientific study. But I think we have to have that in mind for our MMA patient, that they could wear actually a splint that keeps the bite not exactly so hard together, but a 2-3mm apart, just like where we like our rest over posture to be. Okay. So I thought that would be a really good way to talk about how this procedure would do. And this is this patient. Okay. Before and after, as you can see, profile, nothing too heavy. The nose is not rotated up too much. It was just subtle enough. And
how advanced this technology is and how advanced your diagnostics are. Because based on traditional education from oral surgery and papers, you know, everyone's like, you need 10mm. And so if I'm understanding you correctly, with the advancement of DISE, you can do a lot of precision medicine based on the individual person.
Yeah.
And this technology, while it is available to many, many surgeons don't have it. And so with this technology, we can do a better assessment of how much advancement we need based on the standard 10%.
Yeah, absolutely, Tracy. Not just that, and also think about the aesthetics of it.
And the facial
Once you see this, you cannot unsee it. And sometimes mention that you do a lot for these patients prior to getting them to sleep to surgery. My answer, as someone who's been through surgery, is that there's not enough that can be done because we have control over a certain parameters prior to going to surgery, and we have to maximize that, our planning, our diagnosis, okay, and setting the expectations of what patient would do, how a patient would be able to perform after surgery, what kind of outcome we're expecting. The 86% success rate that comes with a surgery, as per the Holtze paper, and what Zaghi wrote also afterwards in the same cohort of patients, in a cohort of patients, same meta-analysis, more refined version of it. 1/3 of these patients are going to be apnea, apnea index under 5. 2/3 of that 86% are under 10. The number, I mean, so there's a major variability there. So we have to assess after surgery if the patient might need a soft palate surgery. If I see circumferential collapse of the soft palate and we have that kind of concentric collapse happening, guess what? That patient, I can tell the patient, you know what? There is a chance you're going to need soft palate surgery. We might have to do that after surgery. Expect that. Now we have a patient that has been shown real time what is happening with their airway. And you also set the expectations in terms of the fact that it might need another surgery. So they're not surprised. But if you just do the surgery and say, sayonara, bye, I'm gone.
Right.
That is the worst thing that you can do. My job is done as a surgeon. Go ahead, do whatever you want to do at this point. Orthodontist will finish your case and we're over with. Comprehensive care and proper diagnosis takes time ahead of time. And the follow-up of the patients also take time.
Yeah.
Well, it's so multifactorial. It's like, we've talked about this, how you need a team, but if all you're doing as a surgeon is, oh, okay, I'm just going to do MMA and there you go. There's a lot to consider up front and there's a lot to consider after the fact, and to build a good team as a surgeon, and which you have done, is super important. Something too, I mean, we're looking at definitely a lot of the AP aspect, anterior, posterior. And we talked about this the other night when we were just brainstorming about the podcast. We're talking about transverse, right?
Oh.
And there's people, walking into dental offices, which, yay, there's an awareness being raised that transverse expansion is impactful in airway health. I mean, 10 years ago, 5 years ago, that conversation wasn't happening. So it's great. It's on the radar. But now you've got a lot of people like showing up in my practice, Tracy's practice, going, I need 40 millimeters, or I need an intermolar width of blah, blah, blah. And they're looking for this number. And so as an airway surgeon, what do you have to say about those things?
So I certainly have pandered to folks who want this uber wide arches, but we have to understand our limitations.
Yeah.
And my message for this one is that do no harm, because I've been involved in cases that I'm not proud of. Okay. I've been involved in cases that the soft tissue started, receding for these patients. The canines become exposures, dehiscence out of the bone and such. And I get, no matter how great of a surgery that I do, the patients ultimately see what they see in the mouth. Initially, they're going to be happy for a bit, but then they're going to walk away and say, you know what? This team destroyed my mouth. And that happens. It happens more often than you know.
Yeah, it does.
So I get it. Because of the premolar extraction era that was heavy at some point. And it has reduced. It's about 13%. It was a higher number. So whatever our specialty, not specialty, our profession has done has definitely reduced it, the number of premolars that gets extracted. And Stacy, I can't thank you enough on what you mentioned about the power of moms. That is that is really above and beyond, So we're aware that now that the cases that don't need premolar extractions, it's not getting done anymore. The antennas and radar is on. But we have to know that we can expand into bone and not out of bone. Tipping the teeth out, that is long-term, earlier loss of teeth for these folks than ever. An inner canine width, to speak to Dr. Ki-Bum Kim, based on all the research, there's a reason why we have the specialty of orthodontics. They've done the studies. Inner canine width is unstable when you expand it. It is on one of the least unstable movements that we can have, because the teeth always want to go back into their PDL. With SFOT, it can help it somewhat, and then you can expand. But if you want to expand, you have two options. Okay, if you can expand into bone, basal bone, and that is okay. And that's the reason why we have the data now. We have the CBCTs. We need a perio assessment of the patient. Okay, we need to know what kind of phenotype the soft tissue is. Is it thin, thick, so on and so forth. Basic orthodontics, expansion into the bone could cause somewhat of a recession. But if you go for that 43, 45 number for everybody, not everybody can handle that kind of expansion. Anybody can put a lingual distractor and start uprighting the teeth beyond the 90 degrees and basal bone. There is no glory in that. Where a good clinician comes into place is that they learn from their mistakes and don't repeat it again, number one. And number two is the fact they know the limitation of what the jawbone has to offer them. And they will study, they will get all the data, make the proper diagnosis, and don't go beyond those boundaries, so we don't have to deal with things like AGA that we dealt with. That gives this awesome work that we're all doing a bad name. So we have two options, basically, for the mandible. For the mandible, it would be SFOT, expansion of the teeth into the bone. Dr. Mandelaris does a beautiful job. He can add up to 3 millimeters of bone on the buccal and lingual and support these teeth when that takes place.
What does just for the listeners, SFOT, people that specialize in doing SFOT?
So it's a surgery that makes corticotomies in the bone, and you add bone, what they call sticky bone, on the outside of the teeth and periodontium. And if the soft tissue is thin, you also thicken the tissue. But the very act of bone grafting does thicken the tissue. So as a result, these teeth that we're expanding, they're going to have much more of a sound periodontium around them to be expanded. So, but also, we have to make a distinction between expanding these teeth out into the bone that we're creating, or actually the structure being expanded. And that is the most stable movement that we have if you have a tooth-borne bone-borne distractor. So just to begin with, that's the mandible. And by the way, one more thing to talk about SFOT is the fact that it creates a wrap phenomena. What wrap phenomena is the high metabolic activity of the osteoclast, osteoblast, bone deposition, inflammation, all of that, and the movement of these teeth just really go in a turbo speed. It's a quantum leap for it in many ways. So you can actually finish your orthodontics faster also. I'm sorry, Tracy, go ahead.
Can you show us a picture of what a mandibular extractor looks like? Just for,
Yeah, sure.
I think like there's so much focus on the maxilla that people don't understand how can we influence the mandible.
Yeah. So this is one of the papers that really got me excited. This is Dr. Sylvan Chamberlain from Quebec. And in his paper, what he wrote, which really got me, because I'm always looking to better our results and outcomes. So he says the forgotten dimension, there's a transverse dimension in this paper. And I really would like everyone to read this. He's just presenting two cases here. And what he mentions is that MME, maxillomandibular expansion, prior to MMA, could be more effective than just MMA alone. Okay. And then, as you mentioned, we're dealing with such a terrible pathology. So if I can maximize the outcome, I have to give the patient that option. And we're on the right track. We're all on the right track. We're all want the same thing for the patient and what we want to do it safely. But in any ways, so in this, a patient that he treated, you can see the V-shaped arch that teeth are lingually inclined, crowning anteriorly. So what he did that's the old symphyseal distractor, which I've used, Bologna distractor by KLS Martin. The cut is made in the symphysis, and the distractor little by little expands the mandible. Same as the maxilla. This though is a lot more is a lot more technique sensitive. Maxilla, you're dealing with a stable, solid, stable entity. Mandible, every single time you open and close, the jaw bows out and you're widening the angles, believe it or not. And it has a flexing into it. So this has to be a very strong device. I've had some of the devices that actually broke at the solder point that was attached to the hyrax. So that patient, by the way, that patient had the MME, and just by doing that, the apnea index went down. We're not fully taken care of, but it went down. I mean, because if you make just a room up top and you don't do it on the bottom, you're missing half of the story. Yes, we want the tongue to raise the roof of the mouth, but also if the tongue has more housing, it can help it. And also one of the other things and this is Stanley brought this up, which to me was brilliant. I love the way he's bringing things. He was like, Reza, we also are splitting the genuglossal muscle, which is right behind the tubercle. And as the jaw is opening, you're stretching the muscle. I was like, wow. Because when I did this for some of our cases that were going to MMA, guess what? The airway expanded immensely. So we don't have enough number of data though.
Right.
Okay? We still need this. Still need a cohort of 40 patients to see what the average would be, what the benefit would be. But I've seen the benefit, but I'm not going to make a full-on blanket statement based on that.
But you're seeing enough, and this is how research starts, right? We start, collaborating, putting our minds together. We see things anecdotally in our practices. We have conversations. And then if it's like, wait, I'm seeing this. And that's what drives the research. It's what drives the literature. So it's people thinking outside the box and wait, what if we do this? Are we going to get more changes with the airway? We've never done that before.
Yeah. But also, Stacy, part of it is that we're off-roading. Okay. Yeah. We're off-roading.
We are.
I mean, to most, this is not standard of care. But those of us who really want to innovate and really want to better the outcomes, we have to start somewhere.
Yeah. And sometimes, and I've talked to so many people about this, that a lot of us have been off-roading for a while, and off-roading is not a bad thing. Off-roading is part of, it's called the practice of medicine for a reason, right? We're trying to do what's best for our patients. And you have to look at each patient individually. And some of these patients, like this one that you have up right now with extremely compromised mandible, it's like, okay, maybe we do need to off-road for this patient and see what happens. And there hasn't been a standard of care for airway for this kind of arch yet that makes, sense for that particular patient. So we have to off-road a little bit.
Yeah.
But we're doctors.
But I just recently, I was at a meeting and obviously I would never name the person that was giving the presentation. And he does nice surgery, okay, but showing a patient with stippling of the tongue, and then it was like, listen, surgery first. So the bite goes together. So I'm just going to go to surgery and do MMA. And really, to me, that was missing a great opportunity. If you have stippling of the tongue, that means you don't have enough space. We all know that. So that means you have to do the orthodontics, upright the teeth and the lower jaw. So even with a double jaw, you can segment the upper jaw, and then you really have done this properly.
Yeah.
Okay.
Yeah, you have to look at all dimensions, which is what you're really great about, Reza, is all dimensions. And with that being said, and I hate that it's like, I'm trying to cram as much as I can in an hour. We could make each one of these 2 hours each.
Yeah.
Jaw joints. You've got to look at the joints. This is the foundation of everything. And if you don't have stable joints, it's going to fail.
Yeah, it is going to fail. But before we're going to go to that, we just posted this. I want to share that
Oh,
with you.
this is the distractor. Okay, yeah.
This is the older distractor that we did for this young man. And this is how it would look like. The upper needed a little more help. We didn't do MARPI for the upper. We should have. But this is a bone that was created there. And intramural width went from 29 to 40.5. And look at the airway changes also. This is when now he's ready. His MMA is going to be next month. But the airway changed from 25 to 122. Now, I started working with KLS Martin to try to patent this, basically patent this device that I wanted it to be lingual and not on the buckle, just like the other one that you saw. And it would be only one surgery. Taking this out would be taking out a couple of screws and everything comes out. So what we wound up doing, for example, this young lady that you see here, this is a device that with Jamil and Dr. Kikem, we came up with, which the screws that you can see goes towards the inside, stabilize the device, and the custom brackets will be basically cemented. And this is so much more comfortable and hygienic, and chance of loss of teeth would be a lot less for these patients. And I got to really hand it to Partners Dental. I had this view. I tried to work with a big company to make this happen. FDA was not easy to work with. So we were able to work with people in our industry and make this happen. And those screws that you can see, making the device bone-borne stable and tooth-borne allows us to have a parallel expansion. So
I saw this. I think you posted this on Instagram recently, which I'm going to put all your links and stuff for everybody to be able to follow you, because you post some really amazing cases, amazing before and afters too on your social links.
Oh, thank you. Thank you. But I know in the respect for time, we really want to go to the point of talking about things, but go ahead. Let's begin that.
And it's just, like when I talk to patients and like when I refer to you, I have sent some really young patients to you. I'm amazed at how much we're seeing TMJ issues in young adults. And it's not, typical middle-aged woman. We're seeing it in young girls. We're seeing it in young men. And, when you start talking about joint replacement, any joint replacement, people get nervous, as understandably so.
Rightfully so.
Rightfully so. So, and I know we don't have a ton of time, but if you could talk about like the importance of stability and how you're unique in that you're looking at the jaw joints as well. Not all oral surgeons are looking at the joints or comfortable. They'll do MMA, but they won't necessarily touch the joints.
Absolutely. And that's understandable. And that's the hardest question that we have to answer. And it is not a decision that I take lightly at all for anyone whatsoever. And that's the reason why I have the data, I have my clinical experience, and I do a lot of revisions, some of my work and many from others that come to our office. And this is sometimes becomes a major mess to clean up. And it's hard. It's very hard. Joint surgery is not an easy surgery. It's probably one of the hardest surgeries that we do as oral maxillofacial surgeons. A lot of us do orthodontic surgery. We all do it our own way. But this surgery definitely has a unique place for us. Same as in the orthopedic world, when you go to orthopod, the knees are bone on bone. They don't hesitate to tell you, basically, that you need a total joint. When your hip is broken, you had trauma, guess what? It is a total joint. In the world of medicine, that is not even a question anymore. It's a stigma that was built from 80s, which medicine has gone through that as well, that, the joint, the bad thing to do. We have follow-ups upwards of the 30-year-old follow-up, our joints are coming out. And the question that we have to say is that, what is your problem with this joint? Rather than just using the same old thing, oh, that's too invasive. To me, going through 2-3 procedures is invasive. Days of our lives matter. Stability of our outcome matters. And the best way to do a case with a great outcome is to do it right the first time around. Your best reconstruction is your first chance. That's the reason why. The onus is on us to do all the data collection and go on from there. So stability is so important. We've had an understanding of hierarchy of the movement of the jaws for the longest time. Prophet Turvey Phillips, this is a very famous paper. But one of the things that they didn't take into account was that now we're doing the counterclockwise rotation. We all know the value of that for the airway, from the nose to the base of the tongue and facial profile. And also, the joints have not been assessed. Surgical relapse in the upper jaw happens because we don't have good fixation of the Le Fort 1 osteotomy. And also, we don't graft our outcomes. All my cases are grafted as long as they need it. In the mandible, poor rigid fixation has been a problem, means the screws that be placed for the jaw to come forward. But the most important one is TMJ pathology. Rigid fixation has to be done right so that condyle is in the right place. It's not going outwards or inwards. So we wind up with extensive remodeling. And in this image, this is a chapter I wrote for Dr. Genzer and Dr. Ivory. So this is it's an older case, stock plates were used. What you see in the upper left side, that is segmental osteotomy to expand the upper jaw. What you see in B, image B, that is the splint that maintains the width of the expansion during the surgery. One of the many methods of expansion besides MARPI and such, they all do things differently. But what you see in image E, the screws above the plates, those are the bone grafts that I took from the mandible to graft to that side. So God forbid those plates come out, I have solid bone in the wall of the maxilla, which the four pillars of the face, which we do the piriforms and the zygomatic buttresses, are stable. Now you have a structure that you can count on, and autogenous bone is gold standard. And that's the bone grafting that you see. And sometimes, if we're bringing the upper jaw down, we might have to go to the hip and get the best bone that we can get from the hip. Now, the other part that really comes into play, and this is why the knowledge of MRI matters for us, how do I make that decision for these patients? A lot of it is clinical experience. But the amount of counterclockwise rotation, because the pressure on the condyle is going to be a lot heavier. MRI, Wilks 3, 4, 5. Let's go through that for a second. This displacement has a place for us to understand what's going on in the joint. Not all patients who have this displacement need prosthetic joint, okay? And 30% of the population have this displacement. It's only 2 to 3% of those folks who have symptoms. And then we're going to talk about a cohort of patients that would be the group that we have to concentrate on for this algorithm. And that is only 1.822% of the patients. So Wilks 3, 4, 5. Wilks 3 is anterior displacement without reduction. Wilks 4 is when the condyle is starting to have some sort of arthritic changes. And Wilks 5, when the disc is perforated. If we also on the CT scan, if we see severe osteoarthritis, and some say that, you know what, the joint has a cortex. There's bone loss, but joint has a cortex and we're fine. But the thing is that that's a joint that's not been put through the stress test. The double jaw surgery is a stress test. You're putting the incline on 20. You're asking the patient to see with a clogged artery that otherwise, if they're sitting on a couch, they're going to be fine. You're putting them on that incline. Now that condyle is going to respond so differently. And that's what I see often enough. Also, presence of autoimmune issues. Mm-hmm. We really have about that.
There's such a... My gosh. I mean, we had Robert Lustig on, Dr. Robert Lustig. He was on the podcast a few weeks ago, just talking about the rise of autoimmune disorders in kiddos and teenagers. And I mean, that's a very real thing. We're seeing crazy joint resorption, hip pain. I mean, these kids are inflamed and the body's attacking itself. And you've got to look at these things. I know that because we were going to have you, we're talking about you coming on again as to our ASAP members, because I think too, a lot of dentists that are listening, we have either Pano machines or CBCTs, and a lot more dentists are, putting CBCT machines into imaging into their practices. I'm a huge fan. I can extract the pano, I can extract the
Oh,
stuff, I
yeah.
can see sinus issues, I can see cysts, tumors, what have you, but I can also see the joints in such a unique perspective now that I've never been able to see. So we're excited that you're going to show us, what to look for as dentists, to like raise a flag and start asking more questions because we are seeing, I mean, it is, I just, most of my joint replacement situations have been with late teens and early 20s that
Yes.
you and I have worked together on.
Young girls always, well, I mean, the question that we have to ask, and this is, I'm so thankful to Stanley, because Stanley started really the research projects that we're doing. We're sending the disc of these ICR cases to really understand on a molecular level what's happening to them. And this, hopefully, we're going to have some sort of an answer. But the group that's unpredictable is the young women, the young girls. Why is it happening to them? And why are we seeing a lot of that? Do we have just an undiagnosed autoimmune issue? Because not all rheumatology panels, are going to report
Right.
accurate. We have a lot of false negatives.
Yes, we do.
We
Yes,
do. We
we
have a
do.
lot of false negatives. We just had a patient, for example, even for sleep study portion of it, continuously apnea index of under 5. In lab study, 35 apnea index. I mean, like, don't trust. And because of the DISE, we were able to say, hey, you know what? We got to dig a little deeper. Let's do a PET
Yes,
study
you're right.
to find that out. And that patient otherwise would have gone their whole life with a severe sleep apnea, undiagnosed. So we have to really dig deep. It's on us. We are the gatekeepers in that situation.
We
So
really are. And that's why it's really the onus is to continue your education. Like for healthcare providers, dentists, I mean, we aren't taught airway in dental school, medical school, sleep health. Like, it's an hour or two. I know it's changing, but it's still not enough. And
yeah,
you just really, the American Dental Association says it should be part of our screening and discussion, both for children and adults, having these conversations. And there just needs to be more dentists
yeah,
stepping out and screening because we are, Steve Carsonson calls us the primary care of the airway.
yeah.
And we
Actually, I was
really
talking
are.
to him last night.
Yeah, I love Steve
By
Carson.
the
He's
way,
done a lot.
a little plug for Dr. Carsonson. The new book that he has about dental sleep medicine, the second edition is out on Quintessence. So I really recommend everybody to go and buy that book. He's a super smart, airway dentist that we have, and we really should be proud of him. So get a chance, read that book for sure.
And I'm gonna get these links and stick them in the podcast too. And um, I know we're running out of time, and we want to talk about too what's coming up with Winds of Change and what you've done with Winds of Change. Uh, we just finished the second year, and you've got that coming up in 2026. Tell us about that.
So, what's coming up in 2026 for us is going to be a cadaver lab that we're going to be involved with. So, all these procedures that we do, I can kind of go through what most of those procedures would be. A typical double jaw procedure. We're going to do this procedure on a cadaver, so everyone can see how this works. But also, we're going to be doing cases, for example, this young lady who had double jaw before, and as you can see what's going on, the lips are apart, upper jaw and lower jaw are back. We're going to be able to show everybody, hey, when we have a condyle like that, what do we do? And this is how the resorption happened after the double jaw surgery. As you can see the screws there before for her. And she's one of my favorite patients, absolutely.
Mm.
So, and what we are able to do, we want to show how this procedure works. Going from the double jaw that's failed, the lower jaw has gone back to a situation that's stable. And now we have a bigger airway, and this patient deals with ankylosing spondylitis. So that explains it. So we get to see this procedure as an outcome. Now we are in 3-year follow-up for this lady. How do we go about looking at the function, airway, face, lip competence, occlusion to be able to get the right outcomes? But also, in addition, talk about arthroscopy. Okay, talk about MSTO, symphysial distraction on a cadaver. Talk about MARPI, Inspire, how Inspire works, and how does that fit into everything. So Tracy's going to be speaking. We're going to have also multiple orthodontists who are going to talk about expansion of upper jaw and lower jaw, PT, Myo, as well as two sleep medicine docs, and also the prosthetic portion of it. Dr. Vinci is going to talk about the prosthetic portion of it because it's an important deal. And we have an ENT surgeon, 3 oral surgeons, and hopefully really awesome group panels, and learn from each other, bring our brains together, and also see how this works on a cadaver.
Well,
So,
oh, sorry, Trace, go ahead.
So, I'll just kind of piggyback on that there's never been a course like this.
That's what I was just going to say.
That we're actually going to, and Reza had so many amazing surgery examples that we're really going to kind of dive into carefully diagnosing and trying to understand who's a candidate for surgery and understanding what surgery means and what it looks like. Because I think what I find today, Reza, is people recommend what they can do. Even so, the problem with that is there are procedures that they can't do that are more predictable, and they're not recommending it. And so, hence, and I see that as many trends now. And we're not going. We need to go back and have a proper full evaluation and diagnosis of what's going on. And then, like I always say, in my practice, it's like I understand enough about the procedures to talk about it. I don't need to do it. And I think that's what us need to be. We need to be well-rounded in what we're doing. And the fact that we're doing cadavers and surgery, I mean, that's amazing.
Oh, yes. Amazing.
The second we started that, and I've got to also mention that, really Dr. Mandelaars, kind of spearheaded this. I am so excited about this meeting to sit down and have the roundtable discussions so we all can learn from each other and also have the actual anatomic specimen in front of us.
Right in front of us. Unbelievable. And it's going to be in Chicago this year.
Yes.
And I said, how appropriate. Winds of change in the Windy City. Tracy's hopping off.
Awesome.
She has another meeting, but thanks,
right.
Trace.
Tracy, it was so awesome spending time with you.
But yeah, like this is going to be exciting. And there's never been anything like this.
Yeah.
So I'm excited. And I don't know. Is there a place? Do you have anything yet that people can follow for any information on Winds of Change 2026?
So we're going to be promoting that obviously through our Instagram, the talks, webinars, and such.
So if people, I'll put the link for people to follow you in this podcast, and that if you follow him, you will see when registration begins for the Chicago. It's a 2.5 day?
It's a 2.5 days. We're deciding whether it's going to be Thursday, Friday, Saturday, or Friday, Saturday, Sunday.
Okay.
In terms of, and it's part of it for the international universities will be streamed because it's a state-of-the-art, center. Usually orthopedic surgeries are done there in terms of on cadavers.
Well, now, I saw pictures
and everything else. Yeah.
Yeah, you said, hey, check this out. This is where Winds of Change is going to be next year. I was blown away. The lecture hall is super amazing for learning. And you can definitely tell this was a center geared towards like orthopedic surgeries and stuff. And but oh my gosh, the room where the cadavers will be and the imaging that's going to take place and the learning that's going to take place. Nothing like it. This is where Airway is just going, like you said, we talked about it earlier. It's like a fire hose. It's an exciting time to be in our profession.
Very.
It's like it's light speed.
My uncle is a dentist, and he's the reason why I am a dentist and oral surgeon. And I was at American Association of Restorative Dentistry. And looking at all the presentation and the digital workflows that we have and our understanding and how much broader our spectrum and our lens has gotten so much wider. I'm so proud to be what we're doing. I'm so proud to be a dentist and also involved with Airway because we're starting to own this, and also the joint portion of it is only us. There's no one else.
No one's touching that.
So
Yeah,
great to be in this profession. I'm very
it
thankful.
is. Yeah,
Every day.
anybody listening, considering, I don't know if I want to go into dentistry. I don't know, man, consider it because we really
Absolutely.
are oral physicians. And I think over time, what's going to happen, and it is happening, I'm getting more and more people randomly texting me, did you know there's a link between Alzheimer's and oral health? I'm like, we've known it for years, but it's
Yeah.
just finally coming out that the body is all connected. We have to be talking. We have to be collaborating. The mouth is not a separate compartment from the rest of the body.
No.
We just have,
Unfortunately, it is connected, The
yeah,
insurers tell you, this is the mouth, the teeth, and joint, and this is the rest of the body. No, there is a heavy connection. A favorite, pastime of mine, breathing, is associated with that. So,
favorite. I love that. Hold on, that's a sound bite. A favorite pastime of mine, which is breathing, is associated. I love it. Okay, so I always end a podcast with three just random questions that have nothing to do with what we were just talking about. So I'm going to throw out three rapid fire questions. And then,
go
of
for it.
course, we have to have you on again by yourself, but we are having you on later in the year with Dr. Stanley Liu and Dr. Massimo Shiri. We're going to have the three of you on together, powerhouse. We might have to split that one up into two sections because there is a lot to say. A lot to say.
Agreed. Agreed.
To have you three on together is going to be fun.
Oh, that would be fun.
But I need to have you on again. I just feel like we barely touched on enough. But, it's enough to raise awareness, get people thinking differently. And now more than ever, people have so much autonomy with their health, and you're seeing more people taking charge of their family's health. And it's powerful. And this hopefully gets more information out to people to do more research. And maybe one person listening that was going to jump into a procedure without doing the due diligence might pause today.
Yes.
Right?
I hope so. I hope if there's anything good that come out of this discussion that we had today, I want us to have the bigger picture in mind, not just what you do, not just what in a cultish kind of way has been kind of
like robots, right? Right.
Yeah.
Like, oh, you need MMA.
It's a lot more than just that.
There's more to that. And the other night we were talking about, you basically sculpting an airway. It is art. It is science. It is what we always say in ASAP. What is the diagnosis?
Yeah.
If you're throwing everyone into an MMA, but they also have a joint issue. They also need transverse.
But they could have central sleep apnea. They could be living in altitude that's doing this to them.
Yes, altitude induced, 100%.
I mean, we deal with a lot of patients that come from Colorado. Okay, so in post MMA, some of them still struggle. Even though they have the awesome airway, but we got to ask those questions. We need more precise sleep studies.
Yes. Yeah, and that is something. Gosh, we could have a whole podcast just on the algorithm of the current, process of diagnosing sleep apnea in the first place. And Reza, when you and I started all of this, in lab was the gold standard and everyone was doing it. Now it's HST, home sleep studies, right? I get it. You're in your own bed. I think there's a beauty to that. You're comfortable. You're in an environment that is more familiar, but it's limiting too. And it underestimates the severity of sleep apnea. So we could be missing a lot of people that,
We had two patients these past 2 months, one that we took to surgery, the other one is about to have surgery again. Which actually for the second patient, we're only recommending Inspire because there's enough that I can bring it forward. But the young man that I dealt with and I felt so terrible for is that and he's a guy in unbelievable shape. And ultimately what took place was that through the 3 sleep studies that he did were all 1.5, 1.8. The sleep study that we did in lab was for him was 31 AHI, and RDI was upwards of 40 some odd RDIs. So he would, again, just like the other young lady that I told you, he would have gone his whole life not knowing what was making him up, like a zombie. So no, we have to make sure this is available to more people. This is basically the echo test, the stress test, of your airway, and just like we always discuss, we take care of the symptoms, the hypertension, high cholesterol, diabetes, and so on and so forth. We don't always go to the root cause of it. Also, this major role into all of that.
Unfortunately, medicine, and this is something, Robert Lustig was talking about the other day, just that we're breeding both in, dental and traditional medicine, more of a pharmacological approach of treating symptoms, but not root cause. And, we got to extinguish the cholesterol issue. We got to extinguish the blood pressure issue. But are we asking why they have these things? It's just, oh, your cholesterol's high. We need to put you on a statin. We need it. And then those side effects, so we got to slow down, slow the roll, and take our time and do the due diligence like you're doing up front. And when something doesn't make sense, this is what the practice of medicine is. You just stop and say, we're missing something, and dive deeper. What are we missing? Maybe there's a different
test. You got to ask the questions.
You got to ask the questions. Okay, Reza, here we go. Question 1. What is the last song you listened to?
Actually, it would have been yesterday. It was Layla, Eric Clapton.
Yes, good tune.
Oh, love that tune.
I do too. That is a great one. All right, what is your morning routine?
Coffee.
Yes.
Coffee. It's a lot less. My coffee doesn't go past 12 or 1 o'clock, but I love coffee.
Hey, and we had a good conversation on what you do in the evening for a beverage. You have a favorite tea. What's that?
It's actually, you know what? I'm Iranian by origin, and found one of the Iranian Persian teas that I've gotten started drinking again, along with a sweet portion of emulsified sugar that has saffron in it, which is very interesting. So that's become my late afternoon drink of choice.
Okay, so you go coffee, then you go to your special Persian tea with the saffron and sweetener in it. I said I really want to try it.
Awesome. I'll bring you some. You're going to love it.
It sounds good. I'm excited.
Kind of addictive, though.
Oh, great. Well, I might get hooked. Okay, last question. What is your favorite way to unwind?
It depends on, but between music, painting, the two other things that really I get away from, be able to disconnect would be sailing and hunting. Those two things.
That too. I mean, and you know what? We talked about sculpting and Airway and how artistic it is. And you naturally are very artistic. I have seen your artwork. It's so cool. And you have basically a music studio in your house. I mean, you're a very creative, artistic person. And I don't know that many people understand that about you, but what's your favorite thing to hunt for? I'm adding a fourth one. I've never done this before.
For me, when it comes to hunting, is just the meat that I get to eat, because to me, I respect animals every way you can imagine, but to really complete the circle with great quality meat that has less than 5% fat, for me, elk is amazing. You can have an elk, you can eat for 6 months, you can eat quality, amazing meat and respect the animal that you made the most out of it. So,
you know what's interesting about that? I've never had elk until I went to Jackson Hole. It's delicious. I was nervous. I went to Jackson Hole for my 50th last year. Oh, I got to go back. But they said they had elk burger. And I thought, what? I was blown away at how lean and delicious that elk burger was. So sorry, vegans, hold your ears.
Yeah, I'm so sorry about that. Don't think any
I'm
different
sorry
than,
if you're vegan, vegetarian,
yeah.
but man, it was delicious.
But you know what? I got to tell you, Stacey, the biggest part of it is that you get to really be in nature and actually appreciate the quiet and the beauty of what you see. Last place I hunted was in Utah, and good God, it was just an absolute moment of tranquility and no cell service, nothing. And you're just against this beautiful panoramic view of the mountains, trees, and whatever it would be, the sound of quiet, the sound of silence.
The sound of silence. And we were, I believe, fully designed to embrace and soak that up. And it does something for the mind and the spirit to be out in nature, at least for me. And some people it's the ocean, some people it's the woods, and some people it's hiking. So, well, thank you, Reza. As always, friend, I appreciate any time.
Thanks for having me.
I swear, half the time we get on the phone, I should just hit record because we'll just talk forever. And
These enjoyable conversations, you can't really beat that.
oh, I love it. Well, thanks, friend. And thank you, everybody, for listening. And we'll have ways for you to follow Dr. Movahed in the link. And if you want to learn more about ASAP Pathway, you can sign up for our newsletter to see what we're up to. We appreciate you always joining us, and we'll see you next time.
Thanks so much.
Thanks.
Have a great day, everyone.
Bye.
This podcast would not be possible without the inspiration of my dad, Dan Becker, and creative direction and editing from the talented Jason Becker, Benjamin, and Judah Walker. To stay connected and keep the conversation going, be sure to subscribe to our podcast and visit our website at asappathway.com. And remember, the information in this podcast is for educational purposes only. It's not intended to be used as medical advice to replace your healthcare provider's diagnosis or recommendations.